Thank you for joining me today. My name is William Reisacker, and today we're going to be talking about immunotherapy for environmental allergies. First, we're going to start by looking at our classic triad for allergic rhinitis management. So here is our triad for AR management. At the bottom, the foundation of our pyramid is avoidance strategies. These are our environmental control measures. And while they may alone not be sufficient to keep allergic disease under control, they certainly provide a great foundation so that our medications, our pharmacotherapy, and of course our immunotherapy way at the top of that pyramid can work a whole lot better. So immunotherapy is a disease-modifying therapy as opposed to a symptom-modifying therapy. So it's actually a way of making the body less allergic, and that's done through intentional exposure of the immune system to the allergens that are actually causing the symptoms. And they have to be given in a high enough dose. It has to be given consistently over an adequate period of time, and that's about 3 to 5 years. And if you can do that consistently, we see downregulation of the immune response, which can go for the next 20, 30 years. So it has good long-term results from just about a 4 or 5 year treatment period. So also a patient can have normal exposure to many of the environmental factors and not have the same level of symptoms that they had before. So what are the indications for immunotherapy? Well, this is for IgE-mediated disease. That correlates very well with the symptoms that they're having. So commonly this is done for allergic rhinitis. It can also improve the symptoms associated with asthma. And immunotherapy is very effective for stinging insect allergy. Of course, we try our first-line treatments first, so medications and counseling for avoidance strategies. However, if a person has to use medications all the time, or they're having some side effects from the medications, or it's even too expensive to use all the medications, or it's inconvenient to use them, this is a really nice option to discuss with them. In the past, it's been recommended mostly for moderate to severe symptoms that last across 2 or more seasons or throughout the entire year. But as new ways of delivering immunotherapy come about that are less invasive for the body, there's also a thought that perhaps immunotherapy someday could be considered a first-line therapy. So what are the relative contraindications for immunotherapy? Well, if your patient is on beta blockers, you may want to consider consulting with their physician to see if that medication could be switched. If they're using it for hypertension, then that's a possibility. However, if they're using it for arrhythmias or post-MI, then that might not be a possibility. If for some reason the patient cannot have epinephrine administered, that's a problem because people on immunotherapy should be carrying epinephrine with them. If the patient has demonstrated that they're not adherent to the immunotherapy schedule, or they don't feel they could come in every week for injections, that's also a contraindication. Patients with autoimmune disease must realize that there's a chance that their autoimmune disease could become worse as the immune system is being stimulated by immunotherapy. Now, patients who are pregnant should not be started on immunotherapy. However, if they're already on immunotherapy and doing well at maintenance and they become pregnant, they can continue. Now, if a patient has uncontrolled asthma, they also should not be put on immunotherapy. However, this is a bit of a catch-22 because many patients have uncontrolled asthma because of bad allergic disease. And also, if a patient has immunodeficiency or is immunosuppressed for whatever reason, it's also a relative contraindication because your immunotherapy may not be effective in these situations. So there are many benefits to immunotherapy. It causes a decrease in symptoms, a decrease in the amount of medications that need to be used. The medications tend to work better as well. There's also long-term benefits after stopping the treatment. Quality of life goes up with immunotherapy. It can also have preventative benefits. It can prevent further sensitizations, and it can also prevent the development of asthma. And long-term, it's also been found to be very cost-effective. So what is the mechanism of immunotherapy? What's really happening here? Well, the first step is the allergen is taken up by Langerhans cells. These are the antigen-presenting cells, the dendritic cells. And that allergen then migrates to the regional lymph nodes where T regulatory cells, or Tregs, are stimulated. We see an increase in IL-10 and TGF-beta, and then over time a gradual shifting away from the T helper 2 or the Th2 phenotype, which is pro-allergic, towards a dominant Th1 or pro-bacteria virus fighting phenotype. We see initially that there's an increase in antigen-specific IgE, but over time those levels decrease. Initially, we also see a rise in IgG1, and that goes down, followed by a rise in IgG4, which is associated with symptom relief, but the IgG4 itself is not causing the symptom relief. It's really just a marker that the immune system is being stimulated. And we see that even more dramatic with subcutaneous immunotherapy compared to some of the immunotherapy methods that are done in the oral cavity. Now, over time, we see a blunting in the post-seasonal rise in specific IgE, and then a gradual decline in symptoms with repeated exposures at the same level. So we have a wide variety of concentrated protein allergen extracts available on the market, and the goal is really to get these liquids to the immune system on a regular basis for about 4 years. So in a way, immunotherapy is like sending your immune system to college, where it learns how to be less sensitive to these allergen proteins. And there's been 2 areas of the body where this treatment has been found to be very effective: underneath the skin and in the lining of the mouth. And it makes sense because both of these areas are entry points in the body, and the immune system is very special in these areas. Now, let's take a look for a moment at how immunotherapy has evolved over time. So this is a chronology of immunotherapy delivery techniques. We can see subcutaneous immunotherapy has been around the longest, since the early part of the 1900s. Oral immunotherapy was suggested as early as 1920, and this was done for airborne allergies. However, it's gained new popularity in recent years for food allergy treatment. Nasal immunotherapy has also been suggested throughout the years, although its widespread usage has been limited due to its irritant effects. Bronchial immunotherapy was also suggested, and of course sublingual immunotherapy has been rising in popularity since the 1960s. Now it is the most common method of delivering immunotherapy in Europe, and it's gaining popularity in the United States as well. Oral mucosal immunotherapy is a branching of sublingual immunotherapy using a wider amount of the oral cavity mucosa. So if we go back to our classic triad of allergic rhinitis management, if we consider all the people with allergic rhinitis who are good candidates for immunotherapy, only a small percentage are actually utilizing this therapy. Now, to make matters worse, it's also very difficult for patients to do all of the avoidance strategies that we're asking them to do. So now our pyramid actually looks a little bit more like a Christmas tree. So why is this the case? Why are there so many barriers to subcutaneous immunotherapy? Well, it can be a very inconvenient therapy. It requires weekly or monthly trips to the doctor's office for a significant number of years. You have to wait 30 minutes after each injection, so it can sometimes take 2 hours out of your day when you count the transportation to go to and from the doctor's office. Many children as well as adults are a bit needle phobic. There can be discomfort from the injections. There can be large local reactions, as well as the concern for more distant reactions or generalized systemic reactions. There can be a significant out-of-pocket expense between copayments, deductibles, and coinsurances. Copayments are going up, and years ago, patients usually did not have to pay a copay if they were just coming in for an injection. It was only if they were coming in for an office visit as well. However, now we're seeing more and more that insurance companies are requiring copayments with just an allergy injection. Unfortunately, there's still a lot of lack of awareness amongst physicians about what immunotherapy is, and many patients don't even know that this therapy is existing. And therefore, it's frequently not offered to the mild or moderate patients, only to the most severe. And this is the reason why other methods for delivering immunotherapy have come about. So we have liquid drops that can go underneath the tongue. We have tablets that can dissolve under the tongue. And now we even have a toothpaste that can distribute the allergens all throughout the oral cavity. So why is everybody paying attention to the mucosa of the oral cavity? What are the characteristics of this area of the body that make it such an ideal spot to deliver immunotherapy? Well, the mucosal surfaces have to deal with allergens on a regular basis, and they have to decide whether something is dangerous or whether it needs to be something that we have to defend against. So its default response is set to non-response. Allergens can persist in the oral cavity for up to 20 hours. The dendritic cells, the antigen-presenting cells, are actually in the highest concentration in the body, highest in the vestibular and the buccal mucosa. The density of the T cells are much higher than in the skin, but many of the effector cells, like eosinophils, mast cells, basophils, and the myeloid cells, the plasmacytes, for example, those are in very low levels. There's also the high-affinity IgE receptor in the oral cavity mucosa. However, this is not present in the skin, only the low-affinity IgE receptor. So let's look now at the oral Langerhans cells. These have a pro-tolerogenic effect, so it basically teaches the body what not to react to. We see the rise in IL-10 and TGF-beta, and that's a sign that the T regulatory cells are being stimulated by the oral Langerhans cells. And again, that high-affinity IgE receptor is present. So if you look throughout all the regions in the oral cavity, you can see where those Langerhans cells are at their most dense area. In the vestibulum and the buccal mucosa is where they are most dense, and the least density is actually in the sublingual mucosa. So what's happening when we deliver these allergens to the mucosal surface? Well, the first thing that happens is these allergens are held in the mouth for about 2 minutes. And what happens is they dissolve in the small amount of saliva that coats the mucosa. Now, from that area, they bond with ionic forces to the actual lining of the mucosa, and then they're taken into the surface layers, where they're taken up then by oral Langerhans cells. These oral Langerhans cells migrate to the regional lymph nodes over the next 24 hours, and that's where they stimulate the T regulatory cells. And the mucosa remains unchanged throughout this entire process. So how is sublingual immunotherapy administered? Well, typically the drops or the tablets are placed under the tongue and held for about 2 minutes. At that point, the drops can be swallowed or they can be expelled. And then an escalation schedule worksheet is given to the patient so they can follow how many drops should be used each day. And then the therapy is provided daily from home. The drops can be kept in or out of the refrigerator. It really is best for it to be kept where the patient can remember to use them, because putting drops under the tongue is not something that's part of their daily routine. Usually there's a very small escalation period followed by a maintenance phase. So these are the dissolvable tablets that are available on the market. There's also a dust mite tablet that has recently come on the market. In the United States, there hasn't been a lot of penetration into the market from the tablets. One downside to these is that there's only one allergen in each of these, and patients in the United States tend to be polysensitized, so they're not as interested in getting a treatment with only one allergen in it. So in 2013, the World Allergy Organization came out with a position paper. They were thinking, what about the areas outside of the sublingual region? What about the other areas of the vestibule and the oral cavity itself? And they said, compared to the sublingual region, targeting the vestibule with allergen vaccine has the potential to induce enhanced immune deviation or tolerance, possibly with a lower potential for mast cell-related local side effects. So they took a look at the data that we just presented in the last few slides, and this was their position that they took. So from these ideas came oral mucosal immunotherapy, or OMIT, a way to deliver these allergen extract proteins to a wider area of the oral cavity mucosa. Now, buccal delivery is not a new concept. This is common for many small molecule drugs that are being investigated right now. The goal is to expose the extract to an expanded population of Langerhans cells, and this is administered using a toothpaste delivery vehicle, but potentially other delivery vehicles could also deliver the proteins to the oral cavity mucosa. In the toothpaste matrix, we see an enhanced stability because the the allergens are held in suspended animation in the matrix compared to the shearing forces and the degradation forces with proteases that are seen in liquid 50% glycerin. Also, the distribution of the daily dose to a wider surface area limits the high exposure areas in one particular region, and that potentially can limit local side effects. Brushing also allows for a deeper penetration of the extract and a scraping away of some of the dead surface mucosal cells that can interfere with immunotherapy. Also, integrating a treatment into something that's done as part of a daily ritual should also optimize adherence levels. And currently, OMID is being used off-label in the United States for allergic rhinitis, similar to liquid sublingual immunotherapy. So how do we administer subcutaneous immunotherapy? Well, the total treatment period is about 3 to 5 years, but this is broken up into an escalation phase, which is typically 6 to 9 months. And we have to begin with a very safe starting point, which is a low dose. And then that escalates every week until we end with the maintenance dose, where patients are getting good symptom relief, but they're not getting local reactions that are too large. Each vial is 5 times stronger than the one before during this escalation phase. Now, the maintenance phase is continued until the end of the immunotherapy course. In the second year, we give the injections once every 2 weeks, and after the second year, it's once every 3 to 4 weeks for the rest of the therapy. So in my practice, one of the factors that I've seen that's most associated with effective immunotherapy has been the ability of the patient to adhere to the immunotherapy schedule. And this is a complex interplay between patient, physician, and treatment-related factors. Overall, even for chronic disease, adherence is only about 50% over time. And I did a study a few years ago with a resident of mine where we looked at adherence for both subcutaneous and sublingual immunotherapy, and we found that it was about 50 to 60% over a 4-year course, which was not that bad, because we really encourage our patients to keep adherent with the schedule, so that can be helpful. In other studies, it hasn't been found to be that good. In one real-world adherence study, they found that only 10% of patients were refilling their sublingual immunotherapy prescriptions after a 3-year period. So sublingual immunotherapy is used around the world. It has been studied extensively, and the body of literature behind it is very robust. In Europe, this is the most common way they have of delivering immunotherapy, and it's often reimbursed at the highest level. In the United States, we're slowly catching up. In 2007, about 6% of the U.S. allergists provided sublingual immunotherapy, although I don't think they included ENTs in that calculation. However, 5 years later, that number almost doubled. The most common barriers that have been cited is that it's not yet FDA approved, at least for liquid sublingual immunotherapy. The sublingual tablets are FDA approved. Many of the practice parameters are not established, and we don't really know the most effective dose for sublingual immunotherapy, although it does have a very wide therapeutic window. Currently, it's not reimbursable in the U.S. on insurance, but it can be applied to health savings accounts or flex spending. So off-label usage is actually not an uncommon thing. It doesn't mean that it's been deemed dangerous. About 50% of the medications that we use are used in an off-label fashion. It's unlikely that multi-antigen therapy is going to be approved in the U.S. For sublingual immunotherapy or oral mucosal immunotherapy in the near future. And the reason is that this is a personalized treatment. It's different for each person. So for the FDA to approve it and therefore the insurance companies to cover it, it has to look exactly the same in each patient, like an antibiotic or aspirin or Tylenol. So here we see the reimbursement for sublingual immunotherapy, and in Scandinavia, France, and Italy, there's very high rates of reimbursement, while a very low to none in the United States. So the efficacy of sublingual immunotherapy is no longer in doubt. There are many randomized, double-blind, placebo-controlled trials which have demonstrated that it can prevent the development of new sensitizations. It has good efficacy in both mono and polysensitized individuals. It can even be used in a pre-co-seasonal fashion. It's beneficial in children with seasonal allergies, asthma. It can reduce the risk of development of asthma, and it can also improve the long-term control in people who already have asthma. A Cochrane review in 2010 demonstrated good symptom and medication reduction. Sandra Lin did a great review in JAMA in 2013, which included studies that were not even seen in the Cochrane study. She looked at all age groups and all allergens. This was in drop form only, liquid sublingual immunotherapy, not the tablets. She looked at all allergens and found that there was a moderate evidence for sublingual immunotherapy efficacy for allergic rhinitis, strong evidence for sublingual immunotherapy efficacy for asthma, and a moderate level of evidence for quality of life improvement with sublingual immunotherapy as well. So what are the advantages of sublingual immunotherapy? Well, definitely a more favorable safety profile compared to subcutaneous immunotherapy. It also has potential use in very sensitive patients, so those asthmatics who are under marginal control, people who are at higher risk for anaphylaxis, maybe who have had reactions to immunotherapy in the past, and also patients who are currently pregnant. It also has the potential for use in very young children, although the benefits have been demonstrated in the elderly population. Potentially a reduced discomfort from injections, and also in those needle-phobic patients. This is a good option for them. It can be easy to administer, but not for everybody. I had a patient who was a chef and had no sensation in his fingers from being burned many times, and it was difficult for him to really tell how many drops were going under his tongue. After that first drop, sometimes it's hard to tell the second, third, or the ones after that. It's certainly a more convenient home treatment, which can optimize adherence. However, there's the other side of that coin, that when you send a treatment home with a patient, you really have no way of monitoring what they're doing. And it's been found to have comparable efficacy to subcutaneous immunotherapy. So what are some of the disadvantages of sublingual immunotherapy? Well, for many, it is an out-of-pocket expense. It's unlikely that the FDA is going to approve a multiple allergen preparation anytime in the near future. We don't really know the exact optimal dose for sublingual immunotherapy, but thankfully there is a large therapeutic window. So you really just have to make sure you're getting your patient into that therapeutic window. With liquid glass vials, there's always the potential for spill or contamination when patients are carrying that in their bags. And there's also that loss of monitoring ability that I mentioned before. When you send a patient home with a therapy, it's really difficult to know what they're exactly using it. Are they using it the way you want them to use it? Many times, because they're paying out of pocket, they'll try to stretch out the timing of the drops. So if they're supposed to use 5 drops a day, they may say, well, let me use 2 or 3 drops a day. That way it'll last me longer. For many patients, particularly in the U.S., single allergen preparations are just unacceptable. And also, sublingual drops in the tablets only use a very limited portion of the oral mucosa. So what might be happening is you may be getting competition for those allergen extracts amongst the Langerhans cells, and also a focused level of inflammation, which can lead to oral ulceration, particularly with the sublingual tablets. There's also been the potential for exacerbating eosinophilic esophagitis from allergen extracts that are swallowed. And one strategy for that is to have the patient expel or spit out the allergy extracts. It's also very difficult for very young kids to do sublingual immunotherapy. And this is the group that really can benefit most from this type of therapy because of its preventative effects, and they tend to slip through the cracks. And if you're wondering why it's difficult for young kids to do sublingual immunotherapy, well, have you ever seen a young child try to keep anything in their mouth and then also stay still for 2 minutes while keeping that drop under their tongue? It's not really going to happen. Now let's look at sublingual immunotherapy compared to subcutaneous immunotherapy. Now, there have been several studies which have compared sublingual immunotherapy to subcutaneous immunotherapy, but none of those studies have shown a clear benefit of one method of delivery for immunotherapy over another. Now, the dose of allergen protein that's given with subcutaneous immunotherapy is generally higher than the dose that's given with sublingual immunotherapy. The optimal dose for sublingual immunotherapy has not yet been identified. However, for subcutaneous immunotherapy, it is better quantified, and there's some thinking that low-dose, frequent doses, as seen with sublingual immunotherapy or oral mucosal immunotherapy, may actually have a different, more beneficial immune response than is seen with bolus dosing, with high doses that are given intermittently. Now, safety represents the main advantage of sublingual immunotherapy and oral mucosal immunotherapy over injections. The most common adverse events that we see are just local reactions. It's typically tingling, itching, swelling of the lips or the oral mucosa. It's usually mild and transient over the first week or two. Some other rare adverse events include abdominal pain, vomiting, urticaria, and swelling in the throat area. Although there's no clear system for classifying these adverse events, it may cause withdrawal in a small percentage of patients. And for sublingual immunotherapy, there have been 11 cases of anaphylaxis reported, although no fatalities. And in most of those cases, there was something unusual going on, such as an extremely high dose given or an extract that was created in the physician's office. So for subcutaneous immunotherapy, this is generally considered safe, although local swelling and erythema and discomfort is more commonly seen, and that's why a 30-minute observation period is recommended after injections. And this is also why injections should be performed in the office setting where there is equipment available to manage anaphylaxis. Home administration has been reported, although this is not a common way of delivering this therapy. Anaphylaxis can be seen 1 out of every 33,000 injections, and a fatality in every 2 to 5 million injections. What are some of the predictors for adverse events? Well, that includes asthma, cardiovascular disease, mastocytosis, which is that high density of mast cells in the skin, patients who are on beta blocker therapy, and patients who have had a reaction before to subcutaneous immunotherapy. So some of the possible predictors also include patients that are in their escalation phase when they've had a dose from a new vial, people who are on rush or accelerated escalation schedules, if they're being treated at the height of their allergen season, and also some of the higher risk allergens such as grass. So what have we learned today from this discussion? Well, immunotherapy can be a fantastic treatment for patients who are very symptomatic. Unfortunately, it's very underutilized, but it can also be a potentially dangerous treatment, so it should not be undertaken lightly or performed haphazardly. It should be administered for IgE-mediated respiratory allergy, and it has to be administered in a very precise manner to people who are appropriate for this therapy. You want to explain the concept of immunotherapy to patients. You want to compare it to the use of medications and also the environmental control strategies. You have to explain also to the patient how long they're going to be on the therapy and the risks that they're going to be taking on, both local and systemic. The importance of keeping up with their therapy, of being adherent to the schedule, being consistent, and also to following up with the physician. So we can find out whether or not they're getting better, and then change things as we have to. And also, you have to discuss the various routes of administration, and you have to think about which one fits best into the patient's lifestyle. And really, that's the one that I would recommend to them, the one that's going to fit best into their life. Thanks for joining me today.